Hello, everyone. It's my great pleasure today to talk to Professor Wilfried Randerath, who is a worldwide recognized expert in pneumology, respiratory medicine, and sleep medicine field. And he's the medical director of the Bethanian Hospital in Solingen in Germany, and the director of the Institute for Pneumology at the University of Cologne in Germany. And today we will talk about the paper which was recently accepted for publication in the European Respiratory Journal, which is the statement of the European Respiratory Society and the European Sleep Research Society on the treatment of central sleep apnea with adaptive servo ventilation. Dear Professor Randerath, thank you very much for coming today to talk to us about this paper. And this year, it's 10 years since the results of the SURF-HF trials were published, and these results affected a lot the treatment approach in heart failure patients. So what was the main aim of this statement, which you have been prepared?
Thank you very much, Ludmila, for having me. It's a great pleasure to meet you again and to discuss with you these aspects on adaptive servo ventilation in patients with heart failure and central sleep apnea. Yeah, you mentioned it correctly. 10 years ago, we had this SURF-HF trial, which showed neutral results. That means no difference between those patients treated with adaptive servo ventilation and those with optimal cardiac care. However, in some sub-analyses, there was a higher mortality in those treated with adaptive servo ventilation. As you mentioned, this is 10 years ago. And since then, times has changed, and also devices have changed, algorithms have changed. So we saw over the years several new data and several new studies focusing on adaptive servo ventilation, which showed different results. We did not see papers which showed similar harm as compared to the SURF-HF. And therefore, both societies, the ERS and the ESRS, considered if it was time to reconsider these restrictions, asking if there's new evidence, if we have to advise our patients differently. So that was the background.
And what were the main finding of your analysis and the main key messages from your results, from your work, from your research?
Yeah, one big study recently published was the ADVENT-HF trial, guided by Doug Bradley in Toronto, Canada. And they also studied adaptive servo ventilation as compared to optimal cardiac treatment. And they did not find any difference in terms of harm, in terms of mortality, no improvement also, but some signals of better quality of life, for example. Unfortunately, this study had to be terminated early because of the COVID pandemic and also the Philips recall. And so these results did not answer completely our questions. However, there were also other studies, cohort studies, observational trials, but also RCTs. And they all were included in a meta-analysis. We studied these patients, we studied these investigations, and tried to find out, are there difference in mortality? Is there harm induced by the device? Are there benefits in terms of quality of life, polysomnographic parameters? And what we actually found in this analysis was based on the new findings, based on the new algorithms, based on new devices, there was no signal of any harm of adaptive servo ventilation. There's also no improvement of survival, but there were some informations about improvement of quality of life, sleep parameters, and therefore the study group, the expert group said, based on our analysis, we will treat our patients with adaptive servo ventilation in different situations. So that means in those with predominant obstructive sleep apnea and central sleep apnea in heart failure, but also those with predominant central sleep apnea. And we did not differentiate between the severity of the ejection fraction of the left ventricle. So even if the patients have a low ejection fraction, which was the problem in SURF-HF, we will treat patients with adaptive servo ventilation if there's any argument, for example, in terms of improving quality of life, sleepiness, fatigue. So we do not want to focus, we cannot focus on mortality, but we can focus on other parameters.
Yes, I think this is a very important idea. And based on this analysis, as I understand, this paper is not like guidelines or recommendations, it's just a statement of the expert. But what would be your advice to practical doctors with regards to the use of adaptive servo ventilation in heart failure patients?
Yeah, this is a methodological question. So for the ERS, we have two different documents. One is a guideline, a clinical practice guideline, and the other one is a statement. And they differ in terms of methodology. At the end, for a statement, that you have a less statistical analysis, and therefore you must not say we recommend or we recommend against. This is only possible when you perform a clinical practice guideline. So the findings or the statements always say the panel uses adaptive servo ventilation in this or that situation. We can't say we recommend, but this is a methodological questions. For clinical practice, of course, the audience might be interested in what the panel does. So if the panel says we do it like this may also something which can be an interesting information for people. It's not a recommendation, but it shows how we as a panel perform our clinical practice now and in the future. In addition, there will be a guideline from the American Association of Sleep Medicine. It has been produced over the last 2 or 3 years. I also had the honor to participate in this project, and it's almost close to be finished. We are waiting for the last decisions of the ASM board. A draft has been published in the website of the ASM, and this draft, this guideline has a more rigorous methodology. That means we perform meta-analyses, followed the pico-grade approach, and so this guideline will do recommendations, not only for adaptive servo ventilation, but also for bilevel, for oxygen, for acetazolamide. So different approaches, not only for central sleep apnea in heart failure, but also central sleep apnea in other entities. So we will soon have, in addition to the statement of ERS and ESIS, also a clinical practice guideline. And although it has not been published yet, we have published the draft, and it also was positive in terms of what we discussed today.
Yeah, that's very exciting. I think everyone is looking forward for this paper to be published. But is it coming back to the question of the recommendations? In this statement, you mentioned that the experts, and you have already also mentioned the experts, they use adaptive servo ventilations in patients with heart failure with reduced ejection fraction below 45%. Yes. Would you say that this is possible also outside the expert centers, or you would not recommend to do this in general practice? But if yes, what the doctors should be aware about and cautious about in this situation?
Yeah. So what we state about our clinical practice means we would not use these devices without a supervision in the sleep lab. Mm-hmm. So we initiate treatment in the sleep lab to have a close look on the patients, to see how they respond in terms of central sleep apnea. So that means expert center. That means in a sleep lab, in an experienced sleep lab. It does not mean only in the centers with high-ranked publishing experts. It means sleep labs who have experience with central sleep apnea. And it means also that we would not use any treatment in this group of patients, because this is always a vulnerable group. We would not titrate them at home without supervision, but this is something which is, from my point of view, very clear for this group of patients.
Okay. Thank you very much for this insight into the approach to these patients. Could you please tell more about the process of the research within this paper? Because there are 14 authors in the panel, and I am sure that there was some issues that you could argue about. And so what was the most difficult? What did you argue more and less to come to these conclusions?
Yeah. To write this statement is based on the rules of the European Respiratory Society. There are very clear rules for clinical practice guidelines, but also for statements. So you start by writing a proposal to the ERS. This proposal is reviewed by experts, and if they accept it, then you have to follow the rules, the methodological rules of ERS. So it's not only a personal opinion, but it follows clear rules from the ERS methodology. This includes the definition of a PICO question, one or more PICO questions. This was a short statement, so that means we had only one or two PICO questions. These PICO questions were divided by different aspects. For example, mortality, major cardiac outcomes, sleep parameters, quality of life parameters. And the members of the panel were divided into different groups. And these different small groups, 2 or 3 persons, worked on the specific aspect. For example, quality of life, inpatient with central sleep apnea under ASV or not. And then finally, they put together the literature, evaluated the literature. So we needed a systematic review of literature, but not a meta-analysis, which would be required for guideline. Then we came together. Each group made wrote some statements, and they were discussed in the whole panel. So we had 2 or 3 sessions at the end to discuss these statements and to finalize the statements. And as you asked, what was the most difficult point was to explain how strict we should be with the statements. So as I tried to explain, we did not find harm in the studies. So ASV did not show any harm based on these papers. However, we know that over 10 years, there was a huge narrative that there is a risk treating with ASV. And therefore, we had to make clear that we do not just want to switch over to the other side, but to allow people to say, well, this is still a cautious approach. We accept that people are still wondering if they can start with these treatments. So therefore, we were quite cautious in formulating the statements. And therefore, you read about expert centers, you read about supervision during the initiation process. So this was the most critical point to find these terminology to make clear that we see a change is required. On the other hand, we want to make clear that we are still cautious and do not want to hurry persons to change their treatment.
Thank you very much. For me, because it's always interesting in these big papers how the process is organized and how the experts can deal with the different opinions and finally come to the conclusion, to the definite conclusion. And I have noticed that in the text you mentioned that there was a patient who uses ASV who was invited and was a part of the process of this paper, of this statement. What was the main aim for this, for the inclusion of this patient, and what was his role in this?
Yeah, I think it's very important to include persons who use the devices, who have a different view, a very personal view on such a disease and the treatment of the disease. So we as clinicians, we want to treat patients, but patients have to accept treatments, and they want our advice, and they want to have a good and a wise advice. And therefore, it's good to have a patient or patients included in not only this statement, but all clinical practice guidelines, all statements, to get their input. Do we ask the right questions? How do we interpret the results? What does that mean for patients? So the patient was not included in the scientific evaluation of the studies because he is not a scientist, of course. On the other hand, he was included in the first steps, so defining our questions, and also in the final acceptance of the statement.
Okay, I see, understand. Thank you very much. Yeah, that's a very important position to have patients' view as well, which is important for the clinical follow-up of the patients and their treatment. And then we come closer to the end of our discussion, but I would like to know a bit more about your personal view. Was there something surprising or unexpected for you in this work and this statement? Maybe some results or some conclusions that were surprising or unexpected for you personally?
Actually, I did expect these results mainly because of course, we read a lot in the last years about in the papers and did not see that they follow the SURF-HF results. So this was not unexpected for me. One aspect was very interesting for me. It came from one of our cardiologists who was part of the process. And he mentioned that in the cardiological field, they more and more discuss about palliative care. So for patients where they suffer from dyspnea, they suffer from, they are not able to move anymore because of their heart failure, they are in a very serious and end life situation. And therefore, we discussed if we could recommend ASV also for a group of patients who are in this very limited stage of the disease. So they may have even very highly reduced ejection fraction. They may suffer from dyspnea at rest. And for this group, we also decided to have a statement saying that if there is nothing else you can do and you want to improve quality of life of these patients, then a trial with CPAP or with adaptive ventilation may be considered. So this was something which we did not discuss before, but which was discussed in the panel and also came into a statement.
Yeah, I have read that part, and it was very interesting for me to read this palliative care aspect. That's true. And then, last but not least, what do you think? What are the next crucial steps in this field? The crucial research. What kind of the research is needed to clarify all the unanswered questions in this field?
Yeah, first of all, we have to wait for the ASM guideline if it confirms our findings. If we follow the draft, which was published, we will expect that it will be on the same line. Based on this, the statement and the recommendation, we can start setting up randomized controlled trials in the group the treatment was restricted for in the last 10 years. So we can consider treating these patients in an RCT. I don't think that we get another chance to have such a big trial that as compared to SURF-HF or Randerath, because this takes much money, many years, many centers which recruit patients. So this would be an enormous effort, and it would be hard to find a company which sponsors such a third trial. However, we could try to set up smaller studies in smaller groups, maybe based on the statements we put together. We could select these different statements or the incoming recommendations from the guideline and compare treatments as compared to optimal cardiac treatment or optimal medical treatment. We can compare different treatment options, so ASB as compared to CPAP, ASB compared to oxygen, oxygen with acetazolamide, or all our other combinations. Because you may see that the ASM guideline focuses only on a treatment as compared to sham or no treatment. So that means we do not have a direct comparison between different therapeutical options. This would be very interesting to see.
Yes, thank you very much for this insight into the future steps. That's also very important, and we will be all looking forward to reading, to knowing about those results. Thank you very much, Professor Randerath, for your time, for this opportunity to discuss this important paper with us. We hope that this will be interesting for all our audience. Thank you very much. Have a good day.
Thank you, Mila. Thanks for your nice questions, and thank you that you addressed this topic. Thank you a lot.